A hospital stay is stressful enough on its own, but when you have diabetes, everything gets more complicated. Your meals, your meds, even just the stress of being there can throw your blood sugar completely out of whack. So what should happen when you get admitted? We're going to pull back the curtain and walk through the official playbook, the standards of care, so you can go from just being a patient to being a true empowered partner in your own healthcare. I mean, really think about it for a second. Your whole routine gone. You might not be eating your normal meals, you're definitely under stress, maybe you're even facing surgery. So how in the world does a hospital manage your blood sugar through all of that chaos? Well, let's break down the official guidelines to see exactly how the system is designed to keep you safe. So the moment you're admitted, a clock starts ticking. The very first thing your care team needs to figure out is your baseline. They need a snapshot of how your diabetes was being managed before you even walked through the hospital doors. And this isn't just about paperwork. This is the absolute foundation for your entire in-hospital treatment plan. And one of the very first things that should happen, especially if it's been a little while, is an A1C test. Why? Well, because this one simple test tells a 3-month-long story about your blood sugar control. This is just so important. See, the A1C isn't about what your blood sugar is this very second. It's the big picture. It gives them the average from the last few months, which paints a picture of what your normal actually looks like. That's how they can build a treatment plan that's really tailored to you, and not just some generic one-size-fits-all protocol. Okay, so they've got your baseline from that A1C. Now what? Well, the next step is to set the right goals. What blood sugar number are they actually aiming for while you're in the hospital? And here's something that might actually surprise you. The goal in the hospital is not perfection. This is not the time to aim for that super tight control you might work so hard for at home. Right now, the number one priority is safety, keeping you in a stable range to avoid dangerous highs, and most importantly, to prevent really dangerous lows. And those safety goals actually change depending on how sick you are. So if someone is critically ill, say in the ICU, the team is going to aim for a higher, safer range of 140 to 180. For most other patients, that target can be a little bit tighter. But notice that the floor for both is higher than you might expect. That's on purpose. It builds in a safety buffer to prevent a dangerous low from happening. So how do they stay on top of this? Well, monitoring is pretty much constant, but how often they check changes with your situation. If you're eating, they'll check before your meals to make sure they dose your insulin just right. Not eating? Then they'll check you every 4 to 6 hours just to see where your baseline is. But if you're on a powerful IV insulin drip, that requires almost constant monitoring, sometimes as often as every 30 minutes, so they can make tiny, safe adjustments on the fly. Okay, so we've got the goals. Now for what is probably the most important part, the treatment plan. How should insulin actually be given in the hospital? The standards of care are super clear about what works best and what definitely doesn't. This quote right here from the American Diabetes Association, this is a really big deal. It's basically a direct warning against an old method some places used to use called a sliding scale. This is when insulin is only given as a reaction after your blood sugar is already high. And as you're back to C, that's just a recipe for a roller coaster. And here's exactly why that's such a problem. A sliding scale is purely reactive. It's like playing catch-up all day long, constantly chasing a high blood sugar, instead of preventing it from happening in the first place. That approach almost guarantees you're going to be on a roller coaster of highs and lows. The modern standard of care, it demands a proactive plan. The preferred method, the proactive one, is called a basal bolus plan. Just think of basal insulin as a slow, steady drip from a faucet that covers your body's background needs 24/7. And then bolus insulin is like a quick turn of the tap, a dose given right before you eat to cover the food in your meal. It's proactive and it's so much safer. Okay, now transitioning from a powerful IV drip back to regular insulin shots, this is a really delicate moment. And the key is all about the overlap. Think of it like a relay race. The shot of long-acting basal insulin has to be given a full 2 hours before the IV drip is turned off. This gives that shot time to get up to speed, so there's never a single moment you're without insulin coverage, which prevents a huge rebound high blood sugar. Of course, even with the best plan in the world, things can happen. So the standards are also very clear on how to manage the two biggest risks: hypoglycemia, which is low blood sugar, and severe hyperglycemia, which is very high blood sugar. First, let's talk about the lows. Hypoglycemia is technically any blood sugar below 70, but here's the absolute key takeaway. A low blood sugar event is never just a number that you fix with some juice and then forget about. It's a critical red flag. It's telling the care team that the treatment plan isn't working perfectly and that it needs to be adjusted right away. And I want to be clear, this is a non-negotiable standard. If you have a low blood sugar, your care team is required to review your whole insulin plan and make a change. The goal isn't just to treat the low you just had, but to prevent the next one from ever happening. All right, now on the complete other end of the spectrum, you have high blood sugar emergencies. There are two main ones to know about: DKA, which you see more often in type 1 diabetes, and HHS, which is more common in type 2. Both of these are life-threatening, but they're also very different from each other. Let's just quickly break down the differences. So with DKA, the blood sugar might only be a little over 200. The real danger is that the body is starved for insulin, so it starts burning fat for fuel. And that produces these toxic acids called ketones, which basically poison the blood. Now with HHS, the problem is that sky-high blood sugar. We're talking over 600, which makes your blood thick like sludge and causes extreme dehydration. Just look at the onset. DKA can happen in a matter of hours, while HHS can sneak up on you over days. Okay, so you've been treated, you're stable, and it's finally time to start thinking about going home. This right here is one of the most important and, frankly, one of the riskiest parts of any hospital stay. Here is probably one of the biggest misconceptions about hospital care. A safe discharge plan doesn't start an hour before you're heading out the door. The standard of care actually says that conversation, that planning, should begin on the day you are admitted, and it should evolve every single day that you're in the hospital. So what does a good plan actually include? Well, it has three non-negotiable parts. First is medication reconciliation. That's just a fancy way of saying they carefully check your new hospital meds to make sure they'll work safely with your old meds from home. Second, a clear, structured handoff to your primary doctor so they know exactly what happened. And third, and this is the most important piece for you, is clear, understandable education. Ultimately, this is the entire goal. You should not be walking out that door feeling confused. You should leave with your prescriptions filled, your supplies in hand, and a crystal clear understanding of your new plan, so there is absolutely no dangerous gap in your diabetes care once you get home. So we'll leave you with this question. Now that you know the official playbook, from that very first A1C test all the way to that final discharge checklist, how can this knowledge change your next hospital experience? How can you use it to ask better questions, to really understand the plan, and to truly partner with your care team to be the best possible advocate for your own health?